Hello everyone, this is Module 11, Concepts Related to the Individual, talking about violence. This module will emphasize assault, homicide, and violence toward the self through suicide, as well as issues of neglect, abuse for children, elders, and intimate partner violence. And we will also discuss the nurse's role in assisting victims of violence. Now, over the years, this module has sometimes brought up feelings for students related to their own personal experiences, either personally or someone that they know about violence. So if you have any concerns, please feel free to talk to me. I'm more than willing to help try to mitigate whatever feelings you're having or issues that you may find yourself having from this situation. So the concept of violence is defined as communication or behaviors that threaten or demonstrate harm to yourself or to others. And as mentioned previously, neglect, abuse, and intimate partner abuse, as well as rape trauma syndrome, are going to be the focus of this module. There's a lot of different theories about why violence, primarily violence directed toward others, occurs, and there have been some biological frameworks that say that there are some neurologic issues that predispose a perpetrator to more violent behavior. Certain areas of the brain have shown some distinct differences on imaging studies, the areas of the brain that have to do with mood and affect, the temporal lobe primarily, and other areas in that same general location of the brain. Additionally, there are thoughts that perhaps there are differences or alterations in neurotransmitters that are chemicals in the brain that have to do with mood and that type of behavior, specifically the neurotransmitters of dopamine and serotonin levels. So there can be abnormalities of those particular levels that may be a factor. Additionally, some disorders of the brain, organic brain syndrome, things related to the development of dementia or tumors in the brain or traumatic brain injury. These different disorders have been known to cause more violent behaviors in someone who previously was not prone to that type of outburst or that type of behavior. Genetic influences, there is some theories that say that there is a possible hereditary factor, being that it is more likely that a person who is an abuser has been themselves a victim of abuse in the past. The problem with that theory is that they're not sure whether that is learned through modeling, which the social theorists think that that is a more likely explanation, versus a hereditary genetic predisposition. However, there certainly is a possibility that there's a combination of the two different aspects. Now, a well-known psychiatrist, Freud, said that unmet needs for security and satisfaction and or a poor self-concept led to an internal need to get rid of or discharge hostility, and that the behaviors of aggression and violence supply that individual with a dose of power and prestige that is often lacking and results in increasing their self-esteem, even though it's generally temporary. And then there's interpersonal theories that say that violent individuals have particular personality disorders or certain characteristics that can be well described. Violence is an outburst of physical forces that abuse, injure, or harm another person or an object. And some of the types or examples of violence are assault, homicide, suicide, abuse, neglect can be put in there as well, and certainly intimate partner violence and rape. In general, some of the history of violence over the years, when the Puritans came over from North America to America, the women and children, or actually from Europe to North America, women and children were often viewed as objects, as personal property, as something to be owned and controlled, and the notion that women were subordinate and subservient to men was certainly a commonly held belief, according to historical documents and word of mouth. And also, we've probably all heard, and maybe even said ourselves, to spare the rod and spoil the child. However, there is a big difference between discipline and abuse. And disciplining a child to enhance their behavior and their growth and their ability to function in society is much, much, much different than an abusive type of approach to that. The overall goals, of course, is to prevent violence and abuse from occurring. That's your long-term goal. And early identification and treatment for those victims or the violated individuals is part of that goal as well. So we want to have a good understanding of the factors and the risks that are associated with the cycle of violence, and be able to identify those individuals or those groups of people that are more at risk. Hopefully identifying those risk factors and beginning to intervene so that violence does not take place. There are special education and training and certifications that are available, particularly for nurses that deal with victims of sexual assault. That training is called Being a Sane Nurse, SANE, Sexual Assault Nurse Education. And we actually have a graduate who that was her goal all along when she came into nursing, that and being a forensic nurse, and she has achieved those goals. And she works in Fayetteville and has become a sane nurse and also a forensic nurse specialist as well. The nurse's first priority of care for every victim of violence is to promote patient safety. Once that person feels safe, then other therapeutic interventions can be implemented, but we have to make sure that we promote their safety, either by providing safety for them immediately or educating them and assisting them in developing a safe response and putting them in a safe environment if at all possible. So immediately we would not leave the patient alone. We would not want them, because they're going to be frightened, they're going to be terrified, most likely, of the abuser coming and finding them, or being subjected to some other frightening event. So we want to stay with them, but we also may need, if the abuser is present or the suspected abuser, then we may need to get that patient alone so that we can further investigate and ask some appropriate questions. We definitely want to explain everything that we're going to do. We want to do that in a matter-of-fact way. as we've talked about in other types of questions about a sexual history or whatever, we want to ask those questions as matter-of-factly as possible, trying not to put too much of a judgmental feel on that, because victims of abuse often feel guilty, especially adults of violence, victims of violence feel guilty, they feel shame, they're not sure who to trust, and that kind of thing. So we want to approach it as this is, we know that violence in our society is something that is very commonplace, and so it has become my practice to ask all of my patients about whether they might be involved in an abusive relationship, whether they might have been a victim of abuse recently or in the past, and so you can approach it that way and give that patient the sort of a good window of why you're asking this question, and that may open the door for them to feel a little bit more comfortable about sharing their experiences. Certainly we want to allow the patient as much autonomy as possible. We're not going to, sometimes there's an urge on our part to jump in and take over for them, but really they need to be allowed to be as autonomous and certainly involved in the loop of decision making. This is certainly related to an adult more so than a child, because we do often have to act on their behalf and be their advocate because they are unable to act for themselves or understand the situation. We want to make sure that we are documenting objectively and specifically and accurately without judgment, because when something like this is occurring, it often will go forward into a legal status and may have to go to court, and so we want to be sure that we are using correct terminology when we're physiologically describing symptoms or things that we see. We want to make sure that we use the correct terminology. The plan of care is individualized, of course, as it always is, and it's based on what type of abuse has occurred, what the violent act has been, and what resources are available. For example, preserving evidence, such as taking pictures for sexual assault, then certainly getting a qualified and trained examiner to carry out the evidence gathering is essential. Not only are they well equipped in terms of knowing how to approach that person, but they are also trained in the legalities of how to accurately obtain the evidence and preserve it for chain of custody and all of those other important legal issues. And then, of course, providing the patient with some referrals, some information about resources in the community. And one of the things that your article about intimate partner violence in the rural areas of America clearly pointed out was the differences in the isolation that someone in a rural setting is exposed to, and the part that plays in making it somewhat harder perhaps to leave the abuser, to get away, to trust those around you, to access resources and things. So it pays that wherever you find yourself working, that you become very knowledgeable about the resources for your patients, not only for victims of violence, but for other healthcare needs, home health needs, and that kind of thing, so that you can be a resource, and that you also know where you can find some resources. Would that be a case manager for a hospital setting or wherever you might find yourself being employed? Abuse and neglect that's influenced by a complex interaction of different factors, and these are listed here. Social stresses, financial, lack of jobs, multiple problems that a person might experience that may further decrease the abuser, self-esteem, that might make them lash out in trying to get rid of the hostility and anger against someone who is certainly not at fault by any means, but available to them, and less strong and powerless, and so being able to be dominated that way. So a lot of times it's the initial act of violence that a perpetrator carries out is led up to by a culmination of depleted resources or some of these things. So there's some physical problems, perhaps sometimes even impotence or sexual dysfunction or that kind of thing, or financial strains and stresses from loss of job, or a job that's not able to provide financially for the needs of the family. Emotional issues, maybe there's discord between the husband and wife, and the child is getting the brunt of that dissatisfaction, or the spouse as well. So caregiver role strain. So for example, if a caregiver is dealing with multiple pressures, multiple children, children with special needs, particularly developmental delays, mental delays, even physical as well, and also other personal health care issues as well, then that puts an extra strain on the ability of the caregiver to adapt and adjust and sort of roll with the punches, because it is challenging meeting the needs of someone who is dependent on you, whether that be a child or an elder or someone who is handicapped in some way. And then of course those who abuse drugs and or alcohol have a higher risk for becoming an abuser. The child abuse, some clues that child abuse is occurring is any injury that is inconsistent with the history provided, that's suspicious, and if there's also a delay in seeking care. Now we do have to use some good judgment, and we have to have a high suspicion so that we don't overlook, but we can't jump to conclusions, because of course sometimes an injury, there is a delay in seeking care because it was thought to be more minor than it turned out to be. So for example, a child can injure their ankle and it's thought to be a sprain, and then once the level of bruising is noted, perhaps some hours later or the next day, or it fails to begin getting better and instead is remaining the same or getting worse, then the parents might seek care for the child. So we do have to try to take what the history is and ask ourselves, does this make sense? Is it consistent with what we're seeing here? An injury that is inconsistent with the developmental capabilities of the child. So if the child is unable to physically, would not be able to ride a tricycle at this point, and that is the description of the event, is that they were riding their tricycle and they fell off the tricycle or ran into a building or something along that lines, and it's just impossible that this child at this age would be physically capable of riding a tricycle, then that raises a red flag. As I mentioned, the risk factors are related to stressful life situations and circumstances, lack of support or a limited amount of support. So, for example, a family perhaps that has been uprooted and moved into a new area, and the caregiver is isolated in terms of physical isolation, such as in a rural area, or just social isolation because of being unfamiliar with the area and not having developed any close relationships. A caregiver who is not very educated about child development and about what to expect. That's one of the reasons that the video called Purple Crying has been so useful in helping people to understand that sometimes children just cry, and that things that we need to do to try to help us adjust to that and deal with that without coming to a violent explosion that would then injure the child. The coping strategies that the caregiver possessed for themselves prior to being in this situation with a child perhaps is a huge factor in whether they are going to be able to adapt. Being able to accept frustration, being able to sort of distract themselves, walk away, take a breath, remove themselves from being able to recognize that they are becoming emotionally overwrought and are more likely to lash out at that child. Being able to recognize that and then removing themselves and getting someone to come in and step in and asking someone, could you take the child for a few minutes or an hour or something so that I might have a moment to get away. And a caregiver who expresses an expectation for the child to be perfect or expectations of the child's behavior or capabilities that exceed what is reasonable. And so you might be able to discern some of those red flags whenever you are interviewing a parent or just observing parental interaction with a child, particularly if you were in an office setting perhaps, or certainly in a hospital setting. The longer time you are spending with that child and parent or caregiver, the better you're going to be able to discern that. And if, for example, if you were working in an emergency room and you had just an initial short encounter with someone, it may be hard to really get a feel for that. So the manifestations of abuse, the physical indicators may definitely be vague and nonspecific, such as unexplained burns or bites or bruises, broken bones, black eyes, fading bruises that occur after a school absence. So, for example, for educators or school nurses, if a child has been absent for a day or more and then comes back to school and has some fading bruises, that should be a red flag. Patterns of injury on the surface of the skin that reflect the shapes of objects like cups or coins or handprints, those kinds of things. And as mentioned, an unexplained burn, such as a cigarette burn or scalding or whatever. And some of the behavioral indicators that may lead you down the path of suspecting abuse would be, for the child, an extremes of behavior. Either it's inappropriately adult-like or it's inappropriately infantile, regression. So it's an older child that has regressed to behavior of a much younger child. Delayed physical or emotional development. This would be apparent probably over a period of time as the child was evaluated. And then attempted suicides, of course, and or lack of attachment to the parent or the caregiver. Sometimes speech disorders or poor growth pattern, such as an indicator of failure to thrive, failure to meet those milestones in the developmental stages, or failure to meet those weight and height goals. And as far as manifestations or behaviors that you might see in a parent or a caregiver, they may constantly belittle the child, make disparaging remarks frequently, or they may be unconcerned about perhaps your concerns. If you express some concern over the injury to the child or whatever, they may show lack of concern, or they may refuse offers of help for the child, either medical help or help to assist the child in developmental accomplishments and things of that nature. Or there may be overt rejection of the child. So back in Nursing 102, during the obese section, we talked about observing the bonding between the parents and the infant. Direct eye contact, cuddling, stroking, touching, things of that nature. Comments that are made about wishing that it had been a different sex of child, or lack of interest, showing lack of interest in the child, failing to respond to the child's cries. Those are all potential behaviors of someone who, a caregiver who might be abusive. These are just some pictures, horrible pictures of abuse that has been noted and what that might look like. And oftentimes the abuser will be careful to inflict the injuries on a child or anyone who might be being abused in areas that are normally covered by clothing. And so sometimes then they fail to be seen. Those manifestations fail to be seen, and that's why us as nurses, when we have to provide care for someone, oftentimes we are providing that care in an undressed or a reduced dress situation, and we might be the person that would see that behavior or that evidence of bruising. Other things that they might notice would be soft tissue injuries, complaints of pain, especially if they're chronic complaints of pain, or there may be a history or a description of the child being accident prone. I don't typically believe that that's a realistic terminology, because there may be someone who's a little bit clumsy in things that they're doing, and that might lend them more to having falls and things of that nature. But whenever I hear somebody say, oh, they're just accident prone, it always brings a red flag in my mind. If there is a past history that is known about of sexual abuse or depression or eating disorders, then we would want to have a high suspicion that that pattern of behavior, that older child or even an adult may become involved in abusive relationships later in life. Many times you'll hear someone say that they were abused in one relationship and they got out of that, and then became involved with someone else, and that was an abusive relationship again. Or they were a victim of child abuse as a child themselves, and as an adult they find themselves in an abusive relationship. So having a personal history of prior abuse, sexual abuse, or even an eating disorder makes us suspicious that this might be occurring. Reports of sleep disturbances, especially if they're new, certainly a regression of behaviors in children, such as reverting to bedwetting, sometimes is a red flag of potential for abuse. Self-destructive behavior, cutting, for example, is one way that victims of abuse, sometimes emotional abuse or physical abuse, sort of let out their their pain and their suffering by cutting themselves. That's a way that they can control their own response to what's happening to them. So the nursing care is, of course, protecting the child. Safety is always first. And with child abuse, there is a legal responsibility for nurses, teachers, anyone who is working with children to report any suspected child abuse or neglect. You always want to follow the chain of command wherever you're working. Involve your direct supervisor. Follow the policy of your facility. Involve the appropriate people. But taking care to keep it on a limited need-to-know basis, so that you can establish trust with that child or whoever the victim of the abuse might be. And there would need to be, generally there's a need to take pictures to document factual information about the injuries. Pictures are worth $1 million in terms of documenting injuries and abuse and that kind of thing. And then try to use direct quotes as much as possible in the victim's answer to your inquiries, your questions. Establishing that trust, encouraging the victim, particularly the child, to express their feelings, addressing whatever their immediate needs would be, whether that be for responding to the actual injury, if there's, cutting, bleeding, broken bones, pain related to that, addressing those immediate needs, those physiologic needs, and then moving up the chain of Maslow's hierarchy of needs. And then role modeling behaviors to the parent. And this is particularly important in preventing, of course, the abuse from happening. And that's why early identification of risk factors and situations that promote violence in intimate partners or home situations with children or whatever, particularly with parents, is identifying those at risk and then helping them with education, role modeling, putting them in situations, perhaps groups, where they might have a mentor or someone who's a home health nurse perhaps that's coming out to check on them, that can further kind of put an eye on the situation and begin to identify and correct some misconceptions perhaps, or offer some resources that might be useful in helping that parent cope with the child's situation, particularly, as mentioned, if there is a developmental delay, physical impairment of the child, because we know that that is going to be more stressful for the parents. Now, there's a syndrome called shaken baby syndrome that is just horrific. And at the bottom of this slide, you'll see two hyperlinks that, and I also just pasted the actual web address there. You should be able to click on Alex Braveheart and Justice for Lola Bernicki, and it would take you directly to the website, or you can copy and paste the actual addresses. But anyway, the first one, Alex Braveheart, was not such a happy ending, whereas Lola Bernicki was a little bit more, had a happier ending, and so I felt like I wanted to have one of each, I guess. But the shaken baby syndrome, people, and this is where education comes in, people often don't realize, parents often don't realize, it doesn't take a lot of force to significantly cause brain damage in a baby or a younger child, because they do not have the ability to control their head, their neck muscles are weak, and that kind of thing. And so shaken baby syndrome involves things like retinal hemorrhages and intracranial injury. So this is an injury that would occur that would lead to increased intracranial pressure. We've already learned about all of that and some of the things that, some of the signs and symptoms that would be involved with that, such as headache, vomiting, that kind of thing. But as noted here, they most often will present with respiratory difficulty, including apnea or stopping breathing, and an increasing change in level of consciousness and or seizures. So those are later signs though, because initially there may be no external signs of head trauma, because the problem is that it's been shaken and internally the brain has moved around inside the skull cavity. And so immediately there may be no signs of injury, certainly not to the naked eye. And only when some of these symptoms begin may they even seek care or be taken to seek care. So in general, there should be vague symptoms that would accompany how this child was injured, and the history might change. It's going to be unreliable. And the parents are usually not going to say that they shook the child, or the caregiver, whoever. And so let's look. You can look at those YouTube videos at your leisure. But let's look at what actually happens. The brain injury occurs because of the brain moving back and forth between a firm skull. And so it moves forward perhaps and then backwards, and there's injury on both sides of the brain, both in the front and in the posterior aspect. And as bleeding occurs, this is like bruising on your skin. As the initial injury occurs, then the bruising or the bleeding occurs and spreads out and involves more of the brain tissue, resulting in additional symptoms. So a shaken baby syndrome has these particular symptoms: subdural hematomas that are only visible, of course, with CAT scans or MRIs. They also may often have evidence of bone fractures, particularly rib fractures. And because of the increased pressure and the act of shaking, there are little hemorrhages that show up in the retina. So, of course, the care provider has to be able to look into the retina of the baby and be able to see those retinal hemorrhages. And so it's almost like petechiae. Also, the force of the shaking can be so severe that it can cause the retina to detach, of course, resulting in blindness for the child. But a baby, of course, is not going to be able to give you any history, is not going to be able to express what has been done to them, or even that they're even in pain. So it can be quite difficult sometimes, and only particularly care provider or caregivers, even the person who's done the shaking, often don't seek care, obviously, for the child, because until these severe situations begin happening, severe symptoms like respiratory difficulty, apnea, being unable to wake them, vomiting, things of that nature. Another form of abuse is called Munchausen syndrome by proxy, or MSP. Munchausen was, of course, the person who coined this syndrome and described it. Basically, it is a form of child abuse, but it is difficult to diagnose and treat sometimes. It takes a long time and having a high suspicion, and sometimes victims die before it is diagnosed, and only in retrospect are they able to show that this indeed was Munchausen's. So about 10% of victims die yearly. Now, there is a Munchausen syndrome that a person makes themselves sick. That's one type of self-abuse. And then Munchausen syndrome by proxy is where a care provider causes symptoms in the child. In general, mothers are the most often the abusers involved in this situation. And parents either invent or directly cause or induce their children's illness or symptoms, and then they seek medical treatment. And it's thought that the parents receive some secondary benefit for themselves by their child being sick and having this. And so it's not easily detected by the healthcare professional, but once it is discovered, then usually the child's removed from a home. So my experience as a pediatric nurse, whenever I first got out of nursing school, I worked on the pediatric floor for about 5 years, and we had a child who was a frequent flyer, and the mother came up, and they were there so often that the mother became somewhat friends with the nurse. And the child would usually come in with vomiting, maybe even diarrhea, be dehydrated, come in, stay 2 or 3 days. The mother always stayed with the child, and the child was sort of a quiet child, but there was no concern at that point that there was anything abnormal about their relationship. She seemed attentive to the child and whatever, but the fact that it just kept, the mother always seemed happy, actually, when she was there. Whenever they would come up from the ER, she would say, "It's me again," and just smile, from ear to ear. And as that started to play out, the nurses and the physicians became a little bit suspicious, and ultimately, I can't remember the details of how it was detected, but ultimately they did determine that she was giving the child, I think, Ipecac or something to induce vomiting, and possibly something else to induce diarrhea. That would then, of course, cause the child to become dehydrated and have to be admitted for fluids. So it's kind of a strange situation. So you have to look for the care provider gaining some secondary benefits from the child being sick. And a lot of times the caregiver is not really concerned about whatever the injury is or the illness, or they're detached, like it's almost happening to someone else. They may not respond appropriately to the child if the child's in pain or exhibiting symptoms, or they could be overly concerned with seemingly minor injuries. They may have unrealistic expectations of the child, either in what they're expecting the child to be able to do performance-wise, expecting them to be more advanced in their development skills than they really should be. The parent may also have a history of drug or alcohol addiction, some mental health issues, psychosis perhaps, or they may themselves have a lack of trust in healthcare professionals. So now we're going to move on to elder abuse and the types of behaviors or types of abuse that are perpetrated against elders. In general, this is another population that is vulnerable because of lack of physical strength, sometimes lack of ability to communicate effectively and tell what's going on, being vulnerable in terms of being dependent on someone else to help meet needs, that kind of thing. And so a wide range of abusive behaviors are common, physical, sexual, psychological, and even financial. That is somewhat unique to the elder population. They are much more susceptible to someone taking their money under false pretenses, scamming them. They're not able to discern whether something is true or not, perhaps, or someone that they need someone to help manage their money, and that person then takes their money and uses it for their own personal gain and benefits, and oftentimes then the elder is actually not receiving the care that they need. The elders are probably at highest risk for the financial particularly. Why is it underreported? Because sometimes there's a difficulty in the communication ability of the elder. They may have reduced support systems or people that they have contact with. They may have lack of ability to seek care on their own, or their ability to reach out to others is impaired because of whatever their physical or emotional or circumstances are, and so they don't have someone to report it to. There's this hidden surveillance of elder abuse. That's a hyperlink to that video. If you would watch that, I think that's an eye-opening experience. And the daughter of the father catches the caregiver that's abusing the father. And just think, if you are paying someone and you're trusting them, just like with a child, you're paying them and entrusting them to meet the needs of your loved one, and to find out that they are being subjected to some of the abuse that is depicted there, and even much worse, is a frightening experience. Some of the things that you might see certainly would be a lot of bruising, perhaps this circular injury. Someone was left on a potty chair for an extended period of time, or something was heated up and applied to the skin, causing burns, etc. And some of the manifestations of elder abuse might be in the elder themselves is depression, anxiety, or withdrawal, or even agitation. And that is particularly, you have to have a high suspicion when that represents a change in personality, a change in behavior for that elder. We all certainly know that depression and anxiety is common in the elder population, but something that has begun to develop, you'd have to think about what's going on that might contribute to that. The withdrawal and the agitation probably are a little bit more likely to be recognized as an indicator of something going on. Certainly if there's bruising or lacerations or unexplained fractures, certainly we know that elder population is at higher risk for fractures, but if those fractures are occurring in more than one, or the description of how this occurred does not fit with what you're seeing, then there's should be a high incidence of suspicion. Poor hygiene, or indicators of hunger in the person. Maybe they're not being fed. That would be more of an indicator of neglect, and or being improperly supervised, being left alone in their bedroom while the paid caregiver or whoever is in other parts of the house being unconcerned and not checking on the elder person. And so the elder goes long periods of time without having appropriate supervision and assistance. If there is genital or anal itching, or pain or bruising or bleeding, or the presence of a sexually transmitted disease, certainly that raises the suspicion for abuse, particularly sexual abuse. There is some mandatory reporting. There's a hyperlink here to a video that talks about reporting abuse and helping survivors of domestic violence, and that can be helpful. The U.S. Department of Health and Human Services online has some links to how to and where to report suspicions of abuse. The National Child Abuse Hotline can be done anonymously, and the Department of Child Protective Social Services. An anonymous complaint can be registered. They would then notify the parents of a complaint, and obviously not identifying the complainant, and that an investigation has been initiated. There are some varying thoughts about whether it's better to remove a child if there is suspicion of abuse, or whether that actually does more harm than good. And I won't get further into that, because I think that could be I think there's probably a lot of strong opinions about that. So family violence, of course, also called domestic violence or intimate partner violence. The Centers for Disease Control define this as actual or threatened physical or sexual violence or psychological or emotional abuse directed toward a spouse, an ex-spouse, a current or a former boyfriend or girlfriend, or a dating partner. That's what intimate partner violence is, the definition. And then the other thing is an intentional violent or controlling behavior by a person who has at some point, current, past, or past, been intimate with that victim and may or may not reside in the same household. So that's intimate partner violence. And then, of course, we've already talked about child abuse and elder abuse as also evidence of types of family violence. With intimate partner violence, there is a theory that tries to explain what's going on during this time. The theory is based on the concept of learned helplessness in the victim, and it describes the battering that occurs as occurring in repetitive cycles. And this cycle may last a day. They may go through all three phases in one day, or it may be weeks or months that there's the build up and then the actual event and then the honeymoon phase. That may take days, weeks, even months. And so there's a tension building phase where there's certainly fear, and the victim, especially if this is a recurrent situation, then they would begin to recognize this tension building phase, that there's increased frustration in the abuser, there's specific types of behaviors that are common during this particular period or cycle or phase. Maybe there's an increase in alcohol use or drug use or absences from the home or whatever during this tension building phase, and then something happens that's a trigger. It is important to make the victim realize that that trigger has nothing to do with them. It's not something that they did that caused it, because that's what the batterer, that's what the perpetrator wants them to think. That's what they tell them. If you had just obeyed me, if you'd have had dinner done on time, or if you had cooked what I wanted instead of this slop, then I wouldn't have had to hit you, and you provoked me. And so the blame is being cast onto the victim by the perpetrator. So phase 2 is the most violent and the shortest phase. It's when the actual battering event occurs, and oftentimes in that phase also is when medical attention is sought. Now, of course, we know that there's a lot of times where battering occurs where medical attention is not sought. So, for example, if there's bruises and things of that nature, but if there's obvious broken bone or something more serious, then oftentimes they are taken for medical attention by the perpetrator themselves. But the third phase of the cycle is the honeymoon phase, where the batterer, the perpetrator, becomes remorseful, and they may start doing nice things for the person. They may buy them presents. They may bring them flowers. They may say, "I'm sorry." They may vow never to do it again. They may apologize. And this phase can go on for a very short time or a very long time before the tension building again begins to build up, and then it's just a continuous repetitive cycle, obviously. The abuser has certain characteristics. Usually they suffer from low self-esteem. They may be overly jealous or possessive, or they may sort of have a dual personality, kind of a bipolar mentality, Dr. Jekyll and Mr. Hyde. One minute they're loving and caring and all of those things, and the next minute they are horribly abusive and hateful and angry and lashing out and things of that nature. And sometimes that switch occurs just like the snap of your fingers, and the abuse victim often tries to get really good at being able to know what flips that switch so that they can avoid, they can try to get away from the abuser. The abuser usually has ineffective coping skills. They are unable to cope effectively with frustration, with the cares of life, with normal circumstances that everyone experiences, and they instead lash out in anger and commit these abusive acts. Additionally, they often use physical and emotional abuse as a way to exert power over someone, usually their partner, in terms of dominating them and exerting the control. They often use violence as a method of persuasion. So with that threat of violence overhanging someone's head, the memory that it has happened before, sometimes they actually will threaten them in an effort to get the victim to obey, to do what they want, to follow their instructions, to provide for their needs, almost in a method of slavery, almost. And they frequently degrade, humiliate, and insult someone because they want the victim to be totally dependent on him. And I say him because the largest majority of perpetrators are male on female, although same-sex intimate partner violence does occur. It's much less often, but that's why we have chosen to use this pronoun. The victim has low self-esteem as well. Someone who has been subjected to the degrading, the insulting, the name-calling, the descriptions of, against your physical person, saying you're ugly, who would want you, very negative descriptions of the abuse victim. They begin to believe it, and in this victim, sometimes they commonly adhere to feminine stereotypes as someone who's weak and not able to stand up for themselves and things of that nature. However, I would venture to offer the idea that actually someone who lives through abuse is actually a very strong person, but they are involved in this situation and oftentimes are thought of as weak because of that. They often blame themselves for the abuser's actions because that's what they're hearing. That's what the abuser is telling them, and they begin to believe this, and they feel like, if I had just done this one thing, if I had just had dinner cooked on time, if I had not spoken to the person down the street, to the male person down the street, if I had not worn that pretty dress out to eat, or not said thank you to the compliment that was paid to me by the male waiter, then maybe this, wouldn't have happened to me. So they often blame themselves, and they take on that blame, and most of the time they have become isolated from their family, and they have very, very poor support systems. Now, a lot of times there might be one or more persons that have had some suspicions and may have even tried to intervene, may have even pleaded with the victim to leave the situation or to get help, and because of the fear that the victim has, they don't take them up on it, and so they might further isolate themselves from that person so that the other person that was concerned is not put in jeopardy of their abuser's anger, or because they feel guilty that they are staying in that relationship. They may have grown up in abusive homes, so this is something that feels familiar to them. As I mentioned earlier, a person who's grown up in an abusive home very frequently becomes involved with another abuser. They didn't identify them as that to begin with, but it works out that way very, very often. And they feel very ashamed. They feel guilty. They often feel angry that at their abuser, but at the same time they can't. They feel powerless to take any decisive actions. They're also fearful for their lives, and we know that there's a lot of murders that do occur as a victim of an intimate partner violence, and once the investigation's done, there perhaps has been this longer history of abuse, and sometimes they have even tried to leave, or they even have left, and still the abuser carries out violence against them. So that cycle of abuse is based on that learned helplessness. The victim does not feel that that there is no one that can help them. They're fearful for their life. They're fearful for the lives of those who might try to help them. And so that reinforces their likelihood of staying in that abusive relationship. Health symptoms of victims. I mentioned this before in relationship to children, and so it likewise goes along with the victim of abuse from any age. So I won't spend more time on that. This acronym ABCDE of screening for violence is trying to reassure the person that they are not alone. They are not alone. There are people that want to help them. There are people that are trustworthy that can help them. There are organizations, there are resources out there. They're not the only person who is experiencing violence in this type of situation, that there are other people that have sought help and received help, and that you want to assist them in getting help for themselves. Expressing belief that it was not their fault. That's one of the things that they need to hear over and over, that it was not their fault that the abuser chose to perpetrate violence against them. There is no excuse there, and so making sure that they understand that you believe them and that it was not their fault. Confidentiality of the information shared, and especially with adults, making sure that documentation is with their victim's consent, and reporting it would be with the victim's consent, and that's different than with a child. Now you are required to report any suspected child abuse. As a healthcare provider in this state, you are required, and if you were found to have had a suspicion or had knowledge of it and you didn't report it, then you can be held legally responsible for that. The same thing as a healthcare provider, I believe, for elder abuse. It's not the same thing for intimate partner violence because the victim, if they are of sound mind and can think for themselves, they have the right to refuse assistance or help. And that's one of the things that can be very, very frustrating for healthcare providers and law enforcement people, is that a victim of abuse may frequently refuse to be helped, to refuse assistance for a variety of reasons. Fear of further violence is the number one. But educating them, even if they refuse help, educating them about what is available resource-wise, being very cautious about how you offer that help. So, for example, there may be a helpline number or something along those lines that can be written on a small piece of paper and put in someone's sock or shoe, or put inside a tampon container or a lipstick container, or something where the abuser would be less likely to find that information. One of the things that we want to make sure that we always do when we are screening or asking questions for someone is that we also do that by getting them alone. They are often accompanied to get health care by the abuser, and so we have to find ways to get the victim alone so that we can inquire about the possibility of abuse. And we can do that in various ways. We can be matter of fact and say that it's routine policy and procedure for the patient to be interviewed and examined alone, and then a family member can be asked to join. That can be even the same situation with a child. Or you can be more creative so as not to arouse some suspicion, is that we need to get a urine sample, come with me and I'll take you to the bathroom, and separate that victim from the potential abuser and get them alone, and then ask those questions at that point. Providing for the person's safety is the most important. That's the highest priority goal. It's the highest priority intervention that we want to do. We want to inquire about whether they feel safe at home, and with what has happened, would they be willing to accept help, and what our potential resources are to get them help and to get them to a place of safety. Referring, there's this 1-800 number, 799-SAFE, and you can spell that out so that maybe they can just remember it, or you could write it down as mentioned before and help them put it in a place where the abuser is not likely to be able to find it. Mandatory reporting, documenting, that kind of thing. Documenting using quotes of what the victim has said, as well as taking pictures and being very, very clear about where injuries are, descriptions of the injuries, taking measurements, for example, of bruising, describing the coloring of bruising, because there's a difference between a bruise that is yellow or green is much older than one that is more red or purple. And when the person gives the description of what happened, does that match up with, do the injuries match up with what they're saying, both for children as well as for intimate partner violence? The point at which a person decides to leave is the most dangerous time, one of the most dangerous times. And so we would want to assist that person in developing a safe plan about, if they decide not to seek help now, if they decide not to leave now, but perhaps they're thinking about it or whatever, or for future reference, helping them identify resources as mentioned, or who they might reach out to, where they might go, giving them information about shelters and crisis centers and things of that nature, helping them to make decisions. These are extremely difficult decisions, and sometimes we, as people outside the situation who perhaps have never been in a situation where we might have been frightened of someone that we cared about, or that cared about us, or we thought cared about us, then we may not be able to really put ourselves in their shoes, and we may become frustrated, and it's important that we avoid transmitting that frustration. We want to transmit our care and concern, but not our frustration with them if they choose not to leave at that moment. It's somewhat similar to cigarette smoking, just re-educating and re-emphasizing the need to take action. Eventually someone generally will, and then they are armed with the necessary resources and support services that they need in this particular case. So priority for discharge planning is providing shelter information. Even if they decide not to take you up on it at this point, giving them information, how might they access it. As far as giving them written information, that might not be the best choice, because then that is going to alert their abuser as to the fact that somebody is on to them, and that perhaps the victim has been speaking out of turn and telling about what's been going on, and that sometimes will result in the abuser taking it out again on the victim. In terms of sexual assault or rape, it is a crime of violence. Anger, aggression, and power is not a sexual act. And oftentimes the legal profession has viewed it, especially years ago, and sometimes people in general still view it as a sexual act, or something that is related to lust or passion or whatever. It is absolutely not. It is a means of forcing or coercing or intimidating somebody with the intent to dominate them, degrade them, or express anger. And it is any type of sexual act in which an individual is threatened or forced to submit against his or her will. In general, the largest proportion of rapes occur men raping women, but men are also victims of rape themselves as well. It is a type of sexual assault, and it's an act of sexual intercourse in which the person does not give consent. In children, some of the ways that indicators that rape has occurred might be recurrent or frequent UTIs, might be developing mouth sores such as herpes, genital bruising or tearing or any kind of lesions in the genital region, a vaginal discharge, blood-stained diaper, blood-stained underwear. Of course, we know that during the first 24 hours after birth, a female infant can have some blood on their diaper because of the estrogen and the hormones from the mother. But beyond that period of time, blood on the diaper is abnormal and should be investigated and be suspicious for something happening to the infant. Bedwetting or a change in eating habits, a regression, as I mentioned before, in behaviors can accompany sexual abuse or any kind of abuse, but particularly sexual abuse. And again, there's a lot of fear instilled in children. The perpetrators of abuse, some very often, are people that are trusted by the family, perhaps even a family member, especially if there's incest. It's probably more likely to be carried out by someone that is known to the child than a complete stranger. There is something called a rape trauma syndrome, which develops from the acute phase of disorganization that occurs as a result of the the incident, the rape itself, and the trauma that is associated with that, the physical violence or whatever, and then the long process of coming to terms with that and reorganizing the person's life. So the number one universal response to experiencing a rape, to being a victim of rape, is shame, and that is the number one reason for not reporting it. Helping them to see that it was not their fault, it was not what they wore, it was not anything that they did that caused this to happen, is a high priority in terms of helping them. Obviously, keeping them safe and everything would take the highest priority, but understanding that they are filled with shame, and that keeps people from reporting it. Even children, they know that something is not right, and they feel shame as well. And sometimes that is exacerbated by the perpetrator themselves. Victims that should be prepared, that should be told that their family members are going to respond in different ways. A lot of times, particularly male family members of a female victim of rape, have such a hard time because they feel powerless to protect. They feel like it was their responsibility or their desire to protect this female person, part of their family, whether it's a daughter, a wife, some female person that they're close to, and they may react in anger, not at the person. Sometimes they do blame the victim, mistakenly, obviously, but sometimes they do. And so the victim needs to understand that there's going to be a lot of emotional responses from friends and family members. They're going to want to help, and sometimes they don't really know how to help. So they're sort of three phases of the rape trauma syndrome. The attack, of course. During the attack, the survivors often have that fight or flight response that we all are familiar with. Everybody thinks that they would, if they were in the same situation, would fight or run away. But sometimes a person who has survived a rape freezes in response to an attack. They do that because they are so fearful, and they do that to survive and avoid further injury. They can be paralyzed by fear, and they may not take any action at all. And many, many, many times that is what family and friends and sometimes law enforcement people and legal people use to make it worse for the victim, because they say, why didn't you run? Why did you let them do it? And not realizing that this is a momentary and instantaneous decision that victim has to make, and their priority is surviving and living and moving forward with their life. They might feel very disoriented during the attack and feel like they're watching it happening to somebody else. They sometimes will dissociate themselves from this happening to them, and that is especially true for victims of rape that is a recurrent process. Victims of incest, particularly, they disassociate themselves from being present when this is happening. Sometimes it's happening to someone else. They have to remove themselves psychologically from the circumstances to be able to tolerate it and to be able to move on. And that focus on survival allows the victim to do things that they might not have ever done normally. Sometimes eventually they fight back, or their desire to survive and get away from the attacker can help them to do whatever's necessary to make it through that attack. Immediately after the attack, victims often feel, of course, shock, meaning they're cold, they're faint, they're nauseous, they're disoriented. The actual stress that has mental and emotional stress and physiological stress that has occurred has caused these responses, these physiologic responses in their body. So there's a shifting of body fluids, just like happens in illness or trauma, physical trauma. And certainly there's generalized pain, particularly wherever the attacker touched them or hurt them, a generalized overall body soreness or pain, extreme emotions, extreme ranges of emotions. Sometimes they're very, very, very withdrawn or detached, lack of emotional response or being able to, or they describe the attack in a toneless, sort of monotone, like it's not even really happening to them, and that's their psychological protection factors kicking in. And so the third phase is a reorganization reactions. In trying to understand the impact of this trauma that it has had on your life, the survivor then undergoes a period of reorganization, a struggle to make sense of what happened, to recover the ability to feel safe in their environment, and to cope with any new additional concerns or situations that might have been a direct result of the attack. So, for example, if they became pregnant from the attack, or they had some disease, some sexually transmitted disease that was a result of the attack, or they just no longer feel safe in their environment. If the attack happened in their home while they were sleeping in their bed, then they are likely not to feel safe in those situations. And along with, during this time period, sometimes there are a lot of symptoms that recur and intrude on the survivor's life. No matter what they try to do, they have these recurrent thoughts or images of the attack, or recurrent dreams or nightmares, flashbacks where they feel like the attack is happening all over again. They can physiologically feel the same exact intensity of physical symptoms, emotional symptoms that happened during the actual attack, because that flashback can be so real that it can cause these intense feelings, and they may have episodes of crying, things of that nature. They also may have avoidance symptoms. So one way that they might try to put this event behind them is that they avoid thinking about it at all. They don't want to talk about it. They don't want to report it. They don't want to move forward with any investigation. They don't want to talk it through with a family friend or perhaps their significant other. And sometimes that can create a problem for them personally. They may say, I'm just going to move away from here. I don't want to live in this house anymore, or I don't want to work at this place anymore because I have to go by the place where it happened. They may withdraw from other people or activities that they normally found to be very pleasurable. So certainly some symptoms that are related to depression. They may feel that helplessness and loss of control, and they may lash out in anger at others at seemingly no reason. And then sometimes their body remains in a state of arousal that kind of always keep them prepared for another recurrence of the event. So they may not be able to have deep enough sleep. They may have difficulty concentrating. They may be hypervigilant. They may have to check and recheck constantly the locks on their doors or their windows or whatever. They may have a pronounced startle response to loud noises, or certain sounds may stimulate an overly emotional reaction. They may have other physical symptoms like headaches and nausea and eating disturbances. They may eat too much, or they may eat too little, causing weight gain or weight loss. They may break out in cold sweats, those kinds of things. So with rape, some of the common feelings, of course, are shame, guilt, depression, feeling dirty, They may have a lot of self-blaming, and that sometimes can be encouraged by the way that others respond to them. And so as healthcare providers, we want to make sure that we encourage the thought that it was not their fault. It was not something they did that caused this attack to occur. So the normal ways of coping with things in a rape trauma syndrome is sometimes not enough, and sometimes they self-medicate by resorting to drugs or alcohol or other types of coping that are destructive. So as we are providing them with resources and support and care, we want to educate them about what they can expect, and so that they are not caught off guard. And sometimes we might be the one to point out that it may be that some of their behaviors are in response to this trauma or this rape that has occurred, and put them in contact with some counseling, some group settings that maybe they can share their experiences in a very well protected environment. One thing to keep in mind is that there are some different cultural practices among different peoples of the world that can be mistaken for abuse. So, for example, there is a culture of Jewish population that ties garlic around the wrists of children to help ward off sickness and or bad influences, and that garlic being in contact with the skin can cause blisters. And so we have to think outside the box. We have to take the entire picture into account, the cultural aspects and beliefs and practices, health care wise and otherwise, of where we're living and the person that is in front of us. And so always have a healthy suspicion, but move cautiously and primarily providing safety for your patients. Thank you, and I hope that if you have any questions about any of this information, please feel free to contact me, and we'll clarify anything that is necessary. Thank you so much.